Good day. So today we'll talk about blood gases and pH measurement. So we'll talk about uh, the function of our lungs and kidneys in the regulation of blood pH. What are the different tests that we need to perform in order to evaluate um, acid-base balance? Okay. So first, regarding the function of lungs in the regulation of blood pH. So the function or the action of lungs regarding or towards the regulation of blood pH, you have the excretion of carbon dioxide. Okay, so remember that CO2 is it greatly affects the pH in our blood. Okay, so remember that the relationship of CO2 and pH is inversely proportional. Okay, so remember pH is equal to bicarbonate over CO2. Okay, so pH is inversely proportional to carbon dioxide. Okay, so rapid and very sensitive adjustment in blood pH. So regarding lungs or regarding the excretion of CO2, it has a rapid effect, okay, to your blood pH. Okay, so if there is uh, a decrease or increase in CO2 excretion, it will greatly affect your blood pH. Okay, so the lungs, uh, it maintains a 20:1 ratio between bicarbonate and carbonic acid via excretion of CO2. Okay, so 20:1, 20 bicarbonate, 1 carbonic acid. Okay, so major component. Okay, when you say CO2, oh no, H2CO3 or carbonic acid, main component of that is CO2. Okay, so the ratio between carbonic acid, bicarbonate and carbonic acid, it is 20:1. So the body or the lungs maintain a 20:1 ratio of bicarbonate to carbonic acid via CO2 excretion. Okay, now if there is slow, okay, or non-removal of CO2, the effect of this is, or the result, uh, the patient will have respiratory acidosis. Why? For slow or non-removal of CO2, there is increase in CO2 concentration in blood. Okay? So that increase in CO2 concentration result to decrease in blood pH. Remember, pH and carbon dioxide is inversely proportional. Okay? So increase CO2, decrease in pH. Next, if there is rapid or fast elimination of CO2, this will result to respiratory alkalosis. Okay, why? Let's go back to this equation or formula. Decrease, no. Fast elimination of CO2, meaning there's decrease in CO2 concentration in blood. Okay? So that decrease, the effect is there's increase in blood pH. Okay? So that is for um, the regulation, okay, or the effect of CO2 excretion to blood pH, or the function of um, lungs in the regulation of blood pH. Next, kidneys. So for kidneys, the function of kidneys in the regulation of blood pH first is excretion of acids and the generation and excretion of bicarbonate. And it's also responsible for the reabsorption of bicarbonate. And it also excrete H plus. Okay. And H plus, that's the reason why there is increase in blood pH. Okay. So what are the conditions that are associated with increased bicarbonate? So first is IV infusion of lactate, acetate, and bicarbonate. Okay. Then next is decreased bicarbonate due to diuretics, reduced reabsorption, and chronic nephritis or kidney damage. Okay, so decrease bicarbonate level. Now, if the bicarbonate level goes below 25 millimoles per liter or MEQ per liter, automatic the body will try to reabsorb, okay, reabsorb bicarbonate, okay, if it is less than 25. If it is within 26 to 30 millimoles per liter, then there is continuous excretion of bicarbonate. Okay, so to maintain that 25 millimole per liter of bicarbonate. If it is less than 25, the body will try to reabsorb. If it is greater than 25, it will try to, or it will excrete some of the excess bicarbonate uh, ion. Next, you have the blood buffers. So for blood buffers, I have bicarbonate and carbonic acid, and this is the major buffering system in our body. Okay, so it's a major extracellular blood buffer. So the ratio, remember, it's 20 is to 1. If the ratio between bicarbonate and carbonic acid is 20 is to 1, then the pH of the blood pH is expected to be at 7.40. Okay, 7.40. The range for blood pH is from 7.35 to 7.45. If the ratio is 20 is to 1, and then the pH is 7.40. Okay. Next, you have plasma proteins, hemoglobin, and inorganic phosphate. So these are the blood buffers. So carbonic acid is a weak acid because it does not completely dissociate into H plus and bicarbonate. Now, regarding carbonic acid, why man carbonic acid is the major buffering system in our body? Because it is a weak acid. You cannot use a strong acid as a blood buffer, okay, or as a buffer, because for strong acid it dissociates rapidly. Okay, so mo-dissociate siya into H plus, so meaning there's alteration, uh, abrupt alteration in your pH. Okay, that's why we need a weak acid and a conjugate base for the maintenance of our blood pH. Okay. Plasma proteins have buffering capacity through charges on their surfaces. Okay. So if the pH is alkaline, then the plasma proteins or proteins are negatively charged. Hemoglobin is an effective blood buffer because it can offload its oxygen and combine with CO2. Okay. So that's for blood buffers. Now, next is regarding Henderson Hasselbach equation. So, for Henderson Hasselbach equation, uh, pH is equal to pKa, or the dissociation constant, plus log of the conjugate base and weak acid. Okay? So, the pKa for your carbonic acid is 6.1. Okay? So, this is how you compute. Okay? The pH. Okay, so log of conjugate base and weak acid. So our weak acid being used is carbonic acid, and the conjugate base is bicarbonate. Okay, bicarbonate. Okay, so remember, bicarbonate bicarbonate carbonic acid system is the major buffering system in our body. Okay, so Henderson Hasselbalch equation. So regarding pKa or dissociation constant, if you're using a strong acid, the pKa is lower. Okay? And if you're using a strong acid as blood buffer, it's difficult for your body to maintain that 7.35 to 7.45 because if you're using a strong acid, mo dissociate siya diretso, okay, or rapid end dissociation. So usually mo lean siya to acidic nga environment or pH, okay. Next, parameters in the assessment of acid-base balance. So first is pH. So remember, memorize this one. 7.35 to 7.45. It's a narrow range for healthy blood pH. 7.35 to 7.45. The optimum is 7.40. Okay? So if the pH is 7.40, meaning the ratio between bicarbonate and carbonic acid is 20:1. Okay? If the pH is less than 7.35, that is acidosis, and greater than 7.45, that's alkalosis. Okay. Now, regarding the pH of venous blood, this one, 7.35 to 7.45, that's the reference range for arterial blood. Okay? Arterial blood pH. For venous blood pH, it's 0.03 pH unit lower. Okay? It's because of chloride isohydric shift or chloride shift. Okay? Then, there's a decrease of 0.015 0.015 pH unit per Celsius above 37. Okay, so if your body temp, okay, so for example, your body temperature is 38, then there's an okay, expected decrease in your blood pH. Pila man ang decrease? It's 0.015. Okay, so this will double once mo reach siya og 39 degrees Celsius. Okay? Or times 3 siya if your temperature is 40 degrees Celsius. Okay? So, reason for that one is if there's increase in temperature, there's also increase in the rate of metabolism. And regarding metabolism or catabolism, there's always the production of acid. Okay? Next, partial carbon dioxide. So for partial carbon dioxide, normal concentration, familiarize or better memorize this one, it's 35 to 45 mmHg. Okay? So for PCO2 and pH, you need arterial blood for the specimen. So you need to collect arterial blood, okay, for PCO2 and pH measurement. Um, Concentration, if it is below 35, that's alkalosis. Okay. Lower, uh, lower carbon dioxide level, meaning there's increase in pH. It's because the relationship between pH and carbon dioxide is inversely proportional. Okay. PCO2 greater than 45, that's acidosis. Okay. And regarding PCO2, it's an index or a sign of efficiency, okay, or efficiency. This is efficiency of gas exchange and not a measure of CO2 concentration in blood. Okay, so regarding PCO2, it indicates the uh, proper or the efficiency in gas exchange. It's not indicative of the total CO2 level present in your blood. Okay? So lungs regulate pH through retention and elimination of carbon dioxide. And if there's increase in heparin, because in the collection of arterial blood for pH and PCO2, you're going to use heparin as anticoagulant. If there is increased heparin to blood ratio, the effect of that is there is increase in PCO2 level by 12 to 15%. Okay? Mark artifactual rise. And measured PCO2. Okay, so make sure you have or you maintain the exact heparin to blood ratio if you're using or during the collection of specimen for blood gas analysis. Okay, uh, to avoid uh, false increase in PCO2. So conditions that are associated with increased PCO2, use of illicit drugs like barbiturates and morphine, okay, and alcoholism. Okay, next is bicarbonate. So for bicarbonate, the reference range is 21 to 28 MEq per liter. Then if it is less than 21, that's metabolic acidosis, greater than 28. Okay, so remember pH is equal to bicarbonate over CO2. Okay, so pH and bicarbonate, the relationship between pH and bicarbonate is directly proportional. It's not inversely proportional. So if there's increase in bicarbonate, there's also increase in pH. If there's a decrease in bicarbonate, there's a decrease in pH. Okay? So that's why if less than 21, that's acidosis. If greater than 28, that's alkalosis. Okay? Okay, so next is partial oxygen. So for adequate oxygenation, the PO2 level should be at 81 to 100 mmHg. Okay, 81 to 100. If it is below 81, that's a sign of hypoxemia or decreased oxygen. Okay, so mild hypoxemia 61 to 80. For moderate, it's 41 to 60, and severe, it's 40 or less. So PO2 reflects the availability of the gas in blood, but not its content or the concentration or the true concentration of oxygen. It changes more rapidly than PCO2 or pH. And if we're going to compare venous blood and arterial blood, venous blood has 60 to 70% lower oxygen compared to arterial blood. Okay, because arterial blood is oxygenated. And for venous blood, it's deoxygenated. Usually, the oxygen that was present in your arterial blood was already consumed by the tissues. Okay, so that's why for venous blood, it's lower. It's 60 to 70% lower in terms of oxygen. Now, what are the conditions associated with decrease or low PO2 level? You have myocardial infarction, interstitial pneumonia, and severe congestive heart failure. Now, healthy persons living at higher altitudes will show lower ranges of arterial PO2 because of the naturally lower partial pressure of oxygen in the atmosphere. Now, in higher altitude, your body will try to produce more erythropoietin. Okay? So, nga naman produce og more erythropoietin? It's because na recognize sa body that you're experiencing decreased oxygen uh, or there is hypoxemia, not that severe or mild or moderate, but kanang there's a decrease in your oxygen level. So your body will try to produce more erythropoietin to promote the production of erythrocyte. Okay? So magpadaghan siya cells because ang atong RBC is responsible for carrying oxygen. Okay? Now next you have the four basic abnormal states. Okay? So for this video, we'll discuss the first two, the metabolic acidosis and metabolic alkalosis. Okay, so for the next part, we'll discuss respiratory acidosis, respiratory alkalosis, and the methods or the techniques used in the measurement of blood gases. Okay, so for metabolic acidosis caused by bicarbonate deficiency. So what are the conditions associated with bicarbonate deficiency? So for example, diarrhea, there's bicarbonate loss. Okay. Another cause of metabolic acidosis, you have diabetic ketoacidosis. You're producing a lot of ketones. Okay. For lactic acidosis, there's buildup of lactate. Okay. So example, if you're chronic alcoholic, okay, alcoholism, it, it can cause metabolic acidosis because if you're alcoholic, there's a possibility, or chronic alcoholic, you have damaged liver, okay? Or na-injury na siya sa imong liver. And remember, for our body to get rid of lactate, we need to activate the process called uh, gluconeogenesis. And regarding gluconeogenesis, it is performed by our liver. Okay? So there's a buildup of lactate. Next, renal failure. Okay? Renal failure. The body cannot get rid of um, acids because of renal failure. And for diarrhea, there is bicarbonate loss. Now, if there is acidosis, it is expected that there is efflux of potassium. Meaning, for acidosis, if this is the cell, outside the cell, there is increased H plus concentration. Okay? And diba, potassium is the major intracellular cation. So K plus inside the cell. So our body will try to decrease the H plus concentration by way of exchanging H plus with K plus. Okay? So there is influx, okay, of H plus, so meaning transfer of H plus from extracellular to intracellular. The next, there is a transfer of K plus from intra to extracellular or to your plasma. That's why patients with metabolic acidosis will experience hyperkalemia. Okay? It's because of the exchange, okay, efflux of potassium, efflux of, that's not or, of. Okay? So K plus paingon sa plasma, ang H plus from plasma transfer to intracellular. Okay? So for metabolic acidosis, the compensation is hyperventilation. Okay, compensation. Okay, now let's go back to our formula. pH is equal to bicarbonate over CO2. So for metabolic acidosis, there is a decrease in bicarbonate. That's why there is a decrease in pH. So that's metabolic acidosis. So to compensate this one, remember, if the problem is in the kidneys, or if the problem is metabolic in nature, the compensation should be respiratory. Okay? So, the body will try to compensate via or through regulation of CO2. So, diba, there's arrow down in your pH. So, we need an arrow up. So, how to have an arrow up? By regulating CO2. Unsaon magid ang CO2? By decreasing or through or via decreasing the CO2 level. So we need to lower the concentration of CO2. Okay, so we need to lower the concentration of CO2 in order to increase the blood pH. So after this, the pH will go back to normal or within the reference range. So how to lower CO2 level in our body? Through hyperventilation. Okay? Meaning increased excretion of CO2. Okay? So that's the compensation for metabolic acidosis. So after the compensation, okay, if it is fully compensated, okay, there is low bicarbonate because this is the cause, low PCO2 because of compensation, and pH is less than 7.4 but within the reference range for fully compensated. For partially compensated, okay, it is low bicarbonate, low PCO2, and pH is less than 7.35. Okay? But if fully compensated, pH is less than 7.4 but not less than 7.35 with low PCO2 and low bicarbonate. Okay? That's for fully compensated. Okay? For uncompensated metabolic acidosis, pH is less than 0.7.35, normal PCO2, and low bicarbonate. That's for uncompensated. Okay? Now, the maximal compensation is completed within 12 to 24 hours. That's for metabolic acidosis. So, PCO2 drops 1 to 1.3 mmHg per MEQ per liter fall in bicarbonate. Okay? So that's for metabolic acidosis. For electrolyte imbalance, you have hyperkalemia. It's because of the efflux of potassium. Just to, or that's one way uh, how our body try to compensate or to maintain homeostasis of our blood pH. For hyperchloremia, there is increase in chloride because there's a decrease in bicarbonate. Okay? So we need to maintain uh, sa mga negative o sa mga positive na charges. So if there's a decrease in bicarbonate, your body will try to um, reabsorb more chloride. Okay? Because ni gamay man imong bicarbonate. Okay? So that is for metabolic acidosis.
Okay, so for metabolic acid alkalosis, the cause is there is bicarbonate excess. Okay, so let's go back to the formula. pH is equal to bicarbonate over CO2. Okay, so there's increase in bicarbonate, that's why there's increase in pH. So condition that is associated with bicarbonate excess, you have vomiting. And for metabolic alkalosis, the compensation is to decrease the breathing rate in order to increase the CO2 level. Okay, that's hypoventilation. So corrections, this is hypoventilation. So there's increase in pH because of bicarbonate excess. So the goal of the body is to decrease the pH level by altering the CO2 level by increasing this one. Okay, so you need to increase the CO2 level in order to decrease the pH because pH and CO2 are inversely related. So compensation is through hypoventilation. Correction na, hypoventilation. So after the compensation, there is high bicarbonate level. This is the cause of metabolic alkalosis. There is high PCO2 level. This is the compensation. And pH is greater than 7.4, but not greater than 7.45. Okay, so it's within the reference range. Okay, this is for fully compensated metabolic alkalosis. For partially compensated metabolic alkalosis, you have high bicarbonate level, high PCO2, and the pH level is greater than 7.45. Okay. For uncompensated metabolic alkalosis, you have high bicarbonate level, normal PCO2, and the pH of greater than 7.45. Okay, so that's for metabolic alkalosis. So the maximal compensation is completed within 12 to 24 hours. However, there's a problem with the compensation for metabolic alkalosis because hypoventilation will lead to hypoxemia. Okay, that's why the compensation for metabolic alkalosis is the least effective. Okay, uh, it's because there's a possibility that it will result to hypoxemia if magsikang hypoventilate. Okay. Uh, Next, for every 10 to 10 MEQ per liter rise in bicarbonate, the PCO2 rises by 6 mmHg. And the expected electrolyte imbalance for metabolic alkalosis, you have hypokalemia and hyperchloremia. There's hyperchloremia because you need to excrete a lot, excrete chloride because there's increase in bicarbonate. For hypokalemia, since this is metabolic alkalosis, you have decrease in H plus in your plasma. So you need to transfer H plus from the intracellular space to plasma. Now, in order to maintain electrolyte neutrality, we need to transfer K plus from plasma to the intracellular space. So it will result to hypokalemia. Okay? So this is the part 1 of our discussion regarding blood gas analysis. So for part 2, we'll discuss respiratory acidosis and alkalosis and the different techniques, specimen requirements for blood gas analysis. Okay, so thank you. God bless.